Dear colleagues, thank you for joining us once again for round 2 of the OncoAlert Roundtable table discussions. With the current situation we're facing globally with the COVID-19 pandemic, the OncoAlert network has taken the decision to bring to the scientific community this discussions to bring us a little closer. We want to share and we want to talk about what we know about the COVID-19 virus, especially regarding our cancer patients and the danger that our colleagues put themselves in treating those that are infected. Felipe?
My name is Felipe Hades. I'm a medical oncologist in Brazil, and I'd like to add to Gilles that the aim of this discussion is to deliver to the world the key points oncologically speaking on what we can do to help save lives and what we should do. What should be focusing as a worldwide community in oncology.
Yeah.
We have gathered together not only an international panel of colleagues, but rather a panel of key opinion leaders in oncology from all over the world, and in order to give a better view of the COVID-19 situation worldwide. So what our delegates want to achieve? Our delegates are all stakeholders and represent 5 of the 10 of the top countries with the most number of confirmed cases of COVID-19. And we'll discuss key issues that plague our countries during these hard times, and we'll give their opinions and recommendations as how the countries and institutions are dealing with this issue.
So our esteemed guests in this roundtable are Professor Solange Peters from CHUV Switzerland. She is the ESMO president of head of medical oncology. Professor Toni Choueiri from Dana-Farber, USA, chief of GU Oncology. Professor Gilberto Lopes from the University of Miami, USA. Professor Fabrice Barlesi, Gustave Roussy in France, medical director. Professor Evandro de Azambuja, Jules Bordet, Belgium, head of medical support team. Dr. Nicola Personeni, Instituto Clinico Humanitas, Italia. He's an oncology consultant. Professor Michael von Bergwelt, University of Munich, Germany, Immuno-oncologist and Intensivist. Professor Marina from NCI, Italy, consultant in medical oncology. Dr. Kevin Toni from Leuven in Belgium, he's an oncology consultant. And Dr. Katrin Heinke from the University of Munich, Germany. And of course, we're your co-host. My name is Gilbert Morgan, and with me as always, Felipe Hades. I will be your moderator for today. Felipe?
Okay, due to the size of the panel, this roundtable will be slightly different than the previous one that we made. We have chosen a set of questions that come from our colleagues globally, which the discussants have looked and have time to prepare the answers. For the majority of the questions, the discussion will have 1 minute to answer before moving to the next call. So the moderator will be presenting each question and picking the order of this question answering.
Excellent. With that in place, let's start our discussions. So starting with question 1, I will first of all like to ask everyone of our discussants to please mute their microphones, and then we can start. Question 1, besides social distancing, hand washing, and staying home when sick, what other measures has your country taken in order to fight the virus? When were these measures taken? And so far, what has been the response of the people? And most importantly, what has been the trends of infection up to date? For this first question, Professor Solange Peters.
Yes, thanks a lot. I think in terms of a response from the country and in Switzerland, we had this kind of very strange phenomenon that it's probably 3 weeks ago we had the first cases and we immediately jumped into the epidemic phase with an incredible growth in the number of cases. So I think there were 3 reactions. The first one was to kind of readjust the medical organization. So it's a hospital reaction about having the staff on place and making them behave differently in terms of being very protective in the way they practice. Second thing was probably to change the way we see patients, and we will discuss it further on, who we see, when we see them, prioritize and change our guidelines. and third thing, to change how population should behave behind and beyond the hospital. And speaking about it, we started by having this advice, like you say, hand washing, behaving, taking some distance, 2 meters, and so on and so forth. But already 2 weeks after the first cases were really described, we decided to close the schools, all the nurseries, and ask the Swiss population to stay at home. It's not as binding as other countries. So legally speaking, there's still some rights to go outside in a limited number of people. However, Swiss people are very disciplined, as you know. So if now I look in the streets, there's absolutely no one in the street. So since that time, I think people have adopted a completely different life. No school, no work at all. Nothing happens outside of the hospital today. How is moving the number of cases? At the time being, still increasing. Maybe we are switching from an exponential way to a linear kind of growth, but still there is more cases every day, more deaths every day, and the hospitals are filling in very fast. But I think in terms of reaction, these 3 levels, hospital, medical staff, and population have been taken very fast here.
Excellent. Thank you very much, Solange. Next up, Evandro.
Yeah, here in Belgium, you also took similar measures as in Switzerland. We started by the 13th of March to take some serious measures. And then on the 17th of March, we intensified those measures. So meaning that schools are closed, shops are closed, except for food, pharmacy, hospitals, of course, bank, and post offices. They are still opening. All the other shops are closed, permanent schools are closed. So, and you are also doing a lot of homework for people who can afford the homework. So these are serious measures that have been taken in Brussels, in Belgium, and I think that they have been taken the right time.
Excellent. Thank you, Evandro. Catherine?
In Germany, we have pretty much the same measures. At first, they started to cancel concerts, soccer games with people over 1,000 people attending. And then they closed the schools and tried to transfer as many people as possible to home office. And right now, only supermarkets, pharmacies, and so stay open, and all the other shops, like clothing, whatever, are closed, and we have to stay in, except if we go shopping or take walks or do sports, but we mustn't go out in groups over 2 people right now, and we have to do the safety distance of 2 meters. And yeah, that's pretty much what's been done in Germany right now.
Thank you. Gilberto?
So I had a little trouble muting. So
No
the
problem.
US is a very large federation. So in many ways, you have to think of the country as many countries. Of course, we have states, and each state has had a slightly different way, and some cities and counties are taking the leadership where the national leadership has not. When we look nationally, we have started to have a lot of discussions. Yesterday, Congress signed a $2 trillion agreement that hopefully will try to ease a little bit of all the economic disruption. But in many states, and now most, at least the ones that have been mostly affected, Washington State, California, Florida, New York, as well as some states that have not been affected but have been a little bit more proactive, like Ohio, we have seen a number of the same things that you have discussed. In some cases, cities have had to take the leadership, and the way things are working we can use New York as a great example. So Andrew Cuomo has been one of the politicians that has been at the forefront, and he's trying to both flatten the curve and also increase capacity for the hospitals in the city and state. We do need more of a national response, but of course, as we have different speeds of the epidemics getting to different states and counties at each time, the responses will be more nuanced. We don't think we're going to see a national response.
Excellent. Thank you, Gilberto. Kevin?
Next to Evandro already shared. Next to the things that Evandro already shared with you about Belgium, I think we should stress out that we had also clear guidance from our government starting already 13th of March that all hospitals have to cancel all elective procedure and all possible follow-up consultations. So by this way, we were also able to create a huge amount of space in the hospitals. My appreciation is that this call was answered quite efficiently in our country.
Thank you, Kevin. Fabrice?
Yes, just to add to the measures that have been described for Belgium and Switzerland, which are approximately the same in France, just to stress out the fact that in some area of France, especially in the northeast of France and in the south of France, in Corsica, there were so many patients in the hospital that we had to move some patients from this area to another area where the hospital capabilities were still quite good. Then, just to stress out the fact that I would say it was really difficult, especially in some focused area in France, and sometimes we had to move those patients.
Thank you, Fabrice. Toni?
Yeah, I think Gilberto put it very well in terms of what's happening in the United States overall. I want to say that also, despite we have at the federal national level initiative, especially with the $2 trillion put yesterday by Congress, but also at the state level, the governors have a lot of power also to handle some of the things that they're requiring, including several states advocating for stay at home. And even, the work environment, a lot of us work at very large institutions, medical institutions, and then they have their own, in a way, rules to protect the workers, such as our institution, which transitioned in a record time around 3,000 workers to work from home, even the physicians that don't have to work unless they have to see the patient, especially for outpatient visits. So it's such a dynamic management that changes by the hour.
Thank you very much, Toni. And I guess this gives us pretty much an overview of what is happening around the globe. I know that there's not that much interaction, but I really would like to give everybody out there the feeling of what we're all facing in our respective countries. So with that, we can close this first question and move on to the second question. How are your hospitals dealing with the global problem of not enough PPEs for medical personnel? Reports coming from different countries have shown that healthcare personnel does not have the required material. How does your institution deal with this? And most importantly, what can we do to avoid this situation so that our staff does not get infected? And for this second question, I would like to give the floor to Dr. Nicola Personeni. You're still muted, Nicola.
So now?
Yeah, perfect.
Okay. So, well, first of all, I would like to say that I'm very, very happy and I'm very glad to share with you as a doctor, but also as a former COVID-19 patient, my experience. And I'm also grateful to all my colleagues that supported me and took care of my health condition during my recent hospitalization. So actually, as a medical oncologist, most of my colleagues and myself, we really did not care about, at the very beginning, we did not care about the coronavirus disease. And let's say that we thought that was just a disease happening in Wuhan, China. And China, of course, is very, very far away from Italy. So on February 21st, however, we saw that something was really changing. There was actually the first signal of a spread of the virus across Italy, then across Europe and to the world. And on that date, we also discovered here in Italy the first outbreak of the coronavirus, and this was in Codogno, which was a small town close to the hospital where I work. And coming back to myself, on February 27th, I visited a colorectal cancer patient, which was on adjuvant chemotherapy in the setting of an outpatient clinic. And 5 days later, there was a notice coming that reported that this patient was hospitalized as well due to COVID-19 pneumonitis. Meanwhile, I started developing some myalgias, fever, cough, and also I had an unexpected loss of taste and smell. And at the same time, also my wife, who is also a medical oncologist, she started developing some respiratory symptoms after she had visited a breast cancer patient. And she was reported some days later that she had a coronavirus infection. So at the time, we did not wear, frankly, any PPE. Probably the level of awareness was still quite low. And eventually, my wife and I were admitted in a brand new COVID department after having the result positive for coronavirus, and after having also a CT scan of the thorax, which was very suggestive for bilateral pneumonitis. So we were admitted, and we were treated with oxygen, antibiotics, antiviral therapies. And so after 2 weeks, we were then discharged from hospital after a substantial improvement of our symptoms. So nowadays, we have really staggering figures for Italy. Since the beginning of these pandemics, from 10 to 20% of infected people are healthcare professionals. As of March 24th, more than 2,600 healthcare professionals were infected, and 33 physicians have died following COVID-19 infection. As of March 11th, in my institution, everyone needs to wear at least a surgical mask. And these also is not only for healthcare professionals, but also patients and visitors. Cancer patients attending the patient clinic are requested to always wear a surgical mask. And those who present with fever or respiratory symptoms are asked to stay at home. Don't forget that hospitals are major sites where the virus can easily spread. Beyond PPE, prevention also plays, in my opinion, a very important role. And indeed, it's the most powerful weapon we have against the virus. Every worker who has a body temperature above 37.5 degrees is requested to stay at home and should be tested the following days. Whether or not to test those people who do not show any symptom is still a matter of debate in Italy, but I think also elsewhere. In addition, videos have been created to teach everyone the correct use of PPE, because there's clearly a shortage of PPE, and we cannot waste them. So we are currently facing a very important humanitarian and health crisis. And I think actually that PPE is just the first step, but it's only the tip of the iceberg. And so I think we should also think to change the concept of a patient-centered care, and we should point towards a concept of community-centered care. I think this will be the next steps, the most relevant challenges that we need to face in the near future. Thank you. Thank you for your attention.
Thank you very much, Nicola. Thank you very much for that wonderful first-hand experience of what it's like. Next up, Gilberto.
Thank you, Gil. So in the US, and this is true throughout the country, we do have national stockpiles that have not been released, but states can actually request. Most hospitals do have enough PPEs for a period of about a week, week and a half. And after that, they will have trouble. We have seen trouble in Seattle already. New York is starting to run. We saw media reports yesterday of nurses using plastic bags, garbage bags, as kind of improvised PPE. The governor does say that they do have, it's been a distribution issue, and that's the main problem within the country. It's so large that it's hard to get things around sometimes. What we are asking people in each community is that if you have hoarded masks, to please bring them into healthcare institutions. And if you are a construction company, especially if you have stopped working and you are physically distancing as we promote that people should be, you can bring your N95s, which are actually very similar, the masks that are used in construction, to healthcare facilities as well. And we are seeing donations across the country.
Excellent. Thank you, Gilberto. Next up, Kevin.
Yeah, regarding the situation for PPE in Belgium, actually, stock are really scarce. Apparently, we also had some kind of national stockpile, but it wasn't renewed after the H5N1 pandemic from 12 years ago. So in hospitals, the resources for the moment are scarce, but not exhausted yet. But that's different when we're talking to dentists, primary care physicians, and when we're talking to nurses who are responsible for home nursing or for nursing in centers for older adults. So we try to have good national guidelines for rational use. And also on the hospital level, we have several guidelines which are expected to follow. And also on the COVID wards, to prevent shortages in times of scarce stocks, there is a concept applied which they call cohort nursing. So not every PPE item will be changed after every patient. They can nurse in cohorts, so they can save on PPE by that. And of course, I want to stress out that it's not only PPE, of course, who can protect healthcare workers from transmission and being a vector. Besides this PPE, we also have to be aware that also other protection options are important to prevent us to be a vector of this disease.
Thank you so much, Kevin. Toni?
Yeah, I want to add the fact that, we can manufacture as much as we want. It's going to take time, and distribution, like Gilberto said, is an issue. But it's very, very important to focus in the short term on donations. We know that there are very large companies like Facebook, like Apple, Goldman Sachs, that have ended up, I didn't know that before, end up having masks, end up having N95 respirator. And usually they have these, because to protect them against wildfires or past epidemics. But we're seeing Facebook, for example, giving away a lot of masks. So it will be very, very important for companies, whether they're big and large, to protect healthcare providers, nurses, doctors, and other as much as possible. I mean, there was a very nice article on STAT that, started by saying that we send soldiers for wars with arm. We cannot expand and expect to send healthcare providers without PPE.
Thank you, Toni. Solange?
Yeah, it's sorry, just to stress on that, I think it's very critical that this, I would say, very important material to date is really reserved to the function for which it can serve. Here in Switzerland, you know how Swiss people can sometimes behave. They jumped on the public market on everything which could be protective. Alcoholic solution, masks, and so on, just emptying all pharmacies in the beginning of the epidemic. So that's exactly wrong. I mean, where the masks should go and the different types of masks have guidelines. The FFP2 is for people with invasive kind of role. The normal mask for the other ones, everybody should follow the guidelines because the professionals need to be protected to do their job. In our hospital now, all professionals have a mask the whole day long. They don't eat together and they don't chat about their family. But if the people in the street who are supposed to be at home start to be equipped like doctors, that will not be possible long term and long run. So I think we have to be very careful that now everybody makes the effort to reserve the professional material for professionals, and the other ones just have to stay at home.
Thank you, Solange. Fabrice?
Just to add that it's a huge difference, I think, with our Asian colleagues, where masks are usually, I would say, widely distributed within the population. I think probably when we see images from South Korea, Japan, and everywhere, all the peoples were wearing masks, and I think probably they were more equipped than what we were in Europe, especially. But I would say that in Gustave Roussy, thanks to the discussion we had with our Chinese colleagues and with our Italian colleagues, we were able to order a lot of masks in order to protect both the physicians and the nurses, but also the patients when they come to the hospital.
Thank you for this. And I guess with that, we can close question 2, moving on to question 3. How do you organize your emergency rooms for cancer patients when the virus has spread locally? How do you mobilize personnel so the virus stops spreading? Do you adopt one team with COVID patients and one without? And is there a rotation? And for this, we are going to have Professor von Bergwelt from Munich to tell us about his experience first.
Thank you very much. So we have to say that Germany is quite at the beginning of the pandemic. We have today registered 43,000 positive patients in the country, or people infected in the country. However, the German effort is testing many people. So compared to other countries, this is quite early. So we are just beginning to see significant numbers in our emergency rooms. So what we do for the cancer patients, first of all, we felt that we have to keep unnecessary doctor's visits out of the hospital. So we call every patient every day who is supposed to have an outpatient appointment and make sure that there is a clear indication and make sure there are no symptoms or any kind of suspicion of COVID infection. If so, we reroute these patients to the emergency room to have one focused entry for positive patients. That's the first thing. The second thing is to make the time bearable for the patients, that they are not being seen so often by the doctor. We have started having video consultations or phone consultations, depending a little bit on the technology. And we have also hotlines for the patients because, of course, they're very worried, have many concerns. One hotline we have in Munich, it's run by oncologists, so you can give expert advice, but we have also a hotline by psycho-oncologists for patients who are going into crisis. So once the positive patients enter the emergency room, there is no dedicated area for cancer patients. However, we are trying for the whole hospital to build a system where we have 3 separate areas. So one is for COVID positive patients. One is for patients with a very low likelihood. So let's call this a clean area of COVID. And then there's an intermediate section. This is working for the inpatient setting. And for the ER, we're trying to set this up as we speak. I think maybe I can give you an insight from a video conference we had yesterday with Wuhan. So we organized the video conference with our colleagues from Wuhan to learn from their experience. And they felt it very important to have very strict quarantine measures. So they have also a system with 3 levels of likelihood of an infection, just as we are trying to set it up. They are very, very focused on wearing The masks, as was previously mentioned, we were having the VC yesterday. Everybody on the Chinese end was wearing a mask, although they were not in a problem area. They were sitting in the office. All of us right now are not wearing masks. I think that's very informative, actually. And they have very strict measures. For example, they quarantine the personnel around COVID hospitals. So they have a COVID hospital, and then they want to have all the personnel living basically on campus and not leaving the campus area in order not to bring the virus to their families. And they felt this was one of the reasons why they were so successful. Obviously, this doesn't translate one-to-one to different countries, but I just want to make the point that I think PPEs and strict isolation quarantine is very important.
Thank you very much. Kevin?
Yeah, I can share with you that regarding situation in Belgium, it's quite similar to Germany, actually. I don't see a lot of discordances between the setup, also to try to mobilize the medical teams. As I told before, all elective procedures were cancelled, and all departments who were occupying only with elective procedures, these residents and doctors are mobilized to help with the non-urgent care from departments who are able to take care of the COVID patients at the COVID wards, which are sequentially set up at our institution. We also don't have a clear division between onco-COVID wards, non-onco-COVID wards. Regarding the setup of the COVID wards, there's a very clear there's a very clear separation between the red zone, an orange zone, and a green zone regarding the safety and the level of aerosol production that is expected, which is important in the setup to avoid contamination in the green zones of the COVID areas, where actually all healthcare professionals should feel safe and be safe. I think that's an important step, which will probably be similar in all emergency room setups for COVID patients.
Thank you. Solange? Solange, you're muted.
Sorry, bad attitude. It depends a lot in this country, which is a small one, on the institution type. Most of our hospitals are not cancer center, but general hospitals too. So we do our best to have the COVID patients being separated from all the other services which are not dedicated to COVID. So we do our best for that. But I wanted just to say a word about separated team A and team B, to live in different times, different words, and different environment in order to have a clean team, at least to be safe. I heard that from my Singaporean colleagues who settled this down as soon as the COVID epidemic started. And it's quite important to say that the idea is wonderful. If you can divide the whole team of caregivers into two in the very beginning of the epidemics, you might be sure that at least half of your staff is always healthy and ready to go. Unfortunately, it has some requirements. First of all, your team must be large enough. And second, to divide into two, because it's not only doctors, it's nurses, it's data manager. It's really two different teams for all the care providers. And the other thing is not to be too late. At the time I decided to potentially envisage it, both of my potential teams would have been considered as being dirty already because of the, I would say, contamination in the general population at home, in the street and everywhere. So at the time we did start to envisage it, both our teams, all our staff was considered as potentially already contaminated. So no reason to consider that there was any sparing issue in making people divided into two. So it's a lot of challenges to now have this kind of protective environment. It's more a reactive environment we have to deal with.
Thank you, Solange. Evandro?
People already described a lot of things. What we did in our institution is we prepared one of the floors, especially for COVID patients. So if they require hospitalizations, they have a floor only for them. And also you limit the number of people going to the hospital. So we are not allowing visits anymore, except in very particular scenarios like end of life, or if the patient has some disabilities, including language barriers or something like that. So every patient that comes into the hospital, they have a screening zone. So they want to ensure that they have no signs and symptoms of the disease. And if they have, they are directed to different zones to screen those patients for COVID or not. Also, we have a list of patients that should be in the hospital on that day for blood tests or treatments, and only those patients can get into the hospital. So we took a lot of measures to really prevent COVID to get into the hospital.
Thank you, Evandro. And I guess that will wrap up our third question. Moving on to our fourth question. How often do you recommend the testing of healthcare workers that are in direct contact with COVID patients? What do you do if they come back positive but have no symptoms? Do they continue to work at the risk of spreading? If a person tests positive yet has cold symptoms, would you recommend testing again in 72 hours? What do you do with those who have had contact with infected colleagues who has tested positive? Do you quarantine them or keep them in the rotation? And for this, we would start off with Michael. He seems to be in a call. Is there anybody else that has any input on that? Or hold on, Michael is coming in. Hello?
Sorry, I didn't. Did you talk to me? I didn't have.
Yes.
I couldn't hear it. Sorry, I apologize.
No worries, no worries. I can repeat it. So yes. This is question 4. How often do you recommend the testing of healthcare workers that are in direct contact with COVID patients? What do you do if they come back positive but have no symptoms? Do they continue to work at the risk of spreading? If a person tests positive yet has cold symptoms, would you recommend testing again in 72 hours? What do you do if those who have had contact with an infected colleague who has tested positive, do you quarantine them or keep them in the rotation?
Okay, so I think this very much depends on resources and the likelihood of infected patients in the system. So in the beginning, we actually sent everybody who tested positive home for 14 days until they came back double negative. Now we are obviously getting shorter on resources, and we are keeping everybody in the system who is free of symptoms. But this is basically a moving target. It has to do with what do we have in resources and how likely is getting infected. And the colleagues who work in COVID wards, even if they wear the PPE, we think the likelihood is significant that they will eventually get infected. So it's a different setting than 3 weeks ago, where we are encountering one in 1,000 patients who's COVID positive.
Excellent. Solange?
We did define very strong guidelines that we'd like to follow, even if we have some shortage of personnel. The first one is somebody who is tested positive working in the hospital has to go back home. So timing in 10 days and 48 hours without symptoms. If both arguments are met, 48 hours and 10 days, they can come back without negative testing, because we consider we don't know the value of retesting after some vacation or some recovery at home. So very strong. Nobody tested positive stays in the hospital in every service, I would say, but oncology particularly because of our patients. If you were in contact, I told before, we are all dirty. So if you were in contact with somebody positive, being in your family, being your patients, or whoever, as long as you don't have symptoms and you're not tested positive, you're fully at work and to be employed in your usual position. But we try really not to violate the idea that a positive professional should not treat cancer patients and not expose the rest of the staff to any infection. By doing that, we have very few professionals in the hospital today being infected. And the staff is quite complete, I must say, despite the growing number of cases. So I think it's a strategy we will follow, even if the teams become smaller, no infected people working in the hospital to treat cancer patients.
Thanks a lot. Gilberto?
So we are only currently testing colleagues that actually have symptoms, and even for that, testing is not widespread in every part of the country. In the beginning, it took us about 5 to 6 days to get a result. Now it's been taking about 24 hours, and we're hoping that that's going to be better when the in-house testing starts next week. The CDC has 2 recommendations. There's a recommendation for patients who test, for healthcare workers who test positive. They have to test negative twice, with a 24-hour difference before they come back for work. And there's also new guidance for patients, for healthcare workers who did not get testing. And that is, and of course, this is fluid and it's changing almost every day. And the recommendation is you can only come back to work about 7 days after you have been sick, after you started being sick. And you have to be afebrile, your symptoms have to be improving, and you cannot have any fever for the last 3 days. So 72 hours afebrile, 1 week from the beginning of symptoms, and you should wear a mask all the time.
Excellent. Kevin?
Yeah, also in Belgium, at the moment, we're not able to test healthcare professionals when they don't have symptoms, even not when they're working on the COVID ward, not when they had close contact with the COVID positive patients. So when we have symptoms, testing is available for us. And in case of a positive test, we have to stay at home for 2 weeks after the testing was done. But for the moment, we're not required to test negative before we can go back to the hospital for the reasons Solange stressed out.
Thank you. Nicola?
Yes, there's been a recent proposal from the Italian Association for Medical Oncology to test all oncologists, even if they have no symptoms. In fact, these colleagues, they can be by themselves potential source for virus spreading. And so this is the rationale to provide that test to everyone dealing with cancer patients.
Thank you. Nicola?
Yeah, I think one important point we have to make, there are so many different rules in every hospital. I think the critical issue here is number of test capacity. And I think we all agree that if we could test more, we would. There's one place in Germany, in Cologne, where they are trying to set up basically a high testing capacity, where they're discussing testing the whole personnel, even those asymptomatic and with not a risk contact, maybe twice a week. Obviously, such an approach, if you have the capacities, is perfect, because then you can really also allocate your personnel to the areas, with the high-risk patients and where you have the need and so forth. But all the rules that we were discussing here come out of shortage of capacity. So it's always a compromise. So in a perfect world, or for the next pandemic, this is probably how you should do it, do regular testing of the entire staff.
Thank you very much. Fabrice?
Yeah, clearly, I think that the problem is the capability to test all the patients and all the healthcare workers, and it's why in France it was decided to put positive people at home for 8 days, and if they have no symptoms and at least no temperature for at least 48 hours, they are able to come back with a mask, and they can work, especially if they are not in contact to too many patients or frail patients. But we are not able to retest all of the people. So we are increasing our test capabilities in order to do that. But clearly, I think it's what we should try to do, and it's what people should do if they can do those tests for every patient and every people.
Thank you, Fabrice. Toni?
Yeah, I think it's important to mention it's not just protecting the healthcare provider, but protecting the patient back and forth. We could infect each other. So a lot of measures are fluid and happen at our hospital, and they change, by the day. We started by patient, or people traveling to COVID-19 region, that changed to symptoms, and now even visitors. We allowed one visitor per patient, and now the policy is no visitors at all with patient, and all of us healthcare providers in clinical building where we see patient have to wear a mask all the time, and we converged all our entries, because each building you can have 2-3 entries where you can come from, to only one entry, and everyone had to be screened when they come to our hospital with all the symptoms, have to have their mask for the day, have to swipe their badge, and then they could go. And when they see patient, they have to have the mask on. The patient, if they don't have any symptoms, they don't need to have a mask on, but they also do not, as of today, have any visitors with them.
Thank you, Toni. Solange?
Yeah, I just wanted to have a thought about the testing methodology we are all using. We know that it was not always very accurate to start, but it has its own limitations. The limitation of an RT-PCR test is, of course, the availability of reagents, and we will have this next problem to face for nucleic acid extraction. But more than that, it's a picture of today. So we are just missing and skipping the ones who have probably already made an asymptomatic or not really symptomatic infection, and we don't have the picture of the population. So I just wanted to anticipate that probably some of the shortages we have in describing who is at risk will be overcome by having serology being developed. And I think all our institutions, many private companies are developing serology in order to maybe better define the population of patients, but also the population of caregivers who might be eligible for being less protective in the way they work, and less demanding in terms of swabbing for RT-PCR. So I think it's quite important. We would be surprised probably how many people are serologically positive without knowing that.
Thank you, Solange. Kevin?
Yeah, I want to mention a small last point for this question, taking into account the false negative rate, which is quite high and not acceptable from a clinical point of view in a disease like this, such a contagious disease like this. At our hospital, we put into place a system where every patient who has a clinical suspicious of COVID-19, who has underwent a negative RT-PCR, will go immediately to a low-dose CT protocol. And last weekend they did like 150 or around 200 low-dose CTs. And apparently this confirms what we all know, that we cannot expect the sensitivity of these swab tests to be higher than, let's say, 75-80%. So I think this is an important issue to consider, not only when dealing with patients, but also when evaluating symptoms of healthcare professionals.
Excellent. And with that, we wrap up fourth question. I would like to thank all the discussants. We are keeping time like a Swiss watch. So good job. Moving on to question 5. When it comes to patients, and in the attempt to reduce the amount of times that the patient comes into the hospital for infusions, are you changing the treatment schedules with more room in between? In what situations do you do this? When would you not do this? And is this something that you're already incorporating? Do you think we should adapt guidelines over time? How and when shall we question evidence and negotiate standard of care? This question is special in consideration to our lung cancer patients that have a higher risk of infection and worse outcomes. As a sub-questions, I would like to ask the panel, when it comes down to the visitation policy, what it should be in patients that are admitted into end-of-life care. Should exceptions be made? And for this one, we would start off with Solange.
Thanks a lot. I would just like to address what we can call, it's difficult to call it guidelines, because we have guidelines which are about improving cancer patients' care and outcome. And this guideline will never be changed, or will not be changed by an epidemic or pandemic. But the pandemic imposes us to give some variation in these guidelines in order, and it's very interesting, the publication of JAMA Oncology today was showing that maybe preventing or reducing the number of times patients come to the hospital might be a good way to control the pandemic somehow and to not to impose them any risk. So of course we have to revisit our current guidelines in order to prevent the patients to come too often. So we discussed it before. It's about follow-up visit, which can be scheduled maybe in 3 months from now. It's about double interval, double dose of immunotherapy. And it's also about the risk benefit on a adjuvant chemo in breast cancer. All these kind of things have to be discussed. So what can we do? We cannot rewrite guidelines because they are just circumstances. It's not really guidelines, but we can potentially give something to the community, which is, my opinion, our recommendations to deal with cancer care in the era of COVID pandemic. And with ESMO, and many of you, if not all of you, will be called to help on that, we can put on the website something which will not be published because we hope it will end, but will just be available for the community to let them know how they could adopt to the situation, adopt a new behavior in how you schedule, how you decide for your treatment for all your patients across diseases in the current times. And this would be a simple format like tables, changing the best guidelines into the pandemic guidelines, helping everyone to adopt what can be the best way to spare the outcome of cancer patients. So all of these experts tonight will probably be called to help us building very fast a very pragmatic recommendation type for the ESMO website.
Thank you, Solange. Evandro?
We just finalized the guidelines in February 2020, the guidelines of early breast cancer, and you had to completely adapt these guidelines last week. So we worked in a few days to try to adapt, and the idea behind of this adaptation is to reduce the number of visits to the hospital. Like I'm trying to avoid weekly dose of chemotherapy, so I try mostly 3 weekly if possible. For patients who are only on follow-up or endocrine therapy alone, we call the patient, they don't come to the hospital, we come, we check for symptoms, we check the patient is okay, the tolerance, and if the patient has still medicine. If not, we send the prescription by email or by post to the patient. So we try to minimize the number of patients coming to the hospital. Another thing is like patients in using denosumab for metastatic breast cancer or other tumor types for bone metastasis, they can do the injection at their GP or with a nurse at home. They should not come to the hospital. And also for those patients who are using adjuvant biphosphonates for breast cancer prevention, they should come every 6 months. If the infusion goes in this period of the COVID, we try to avoid. We're gonna delay a little bit. Also for some patients with small luminal A tumors, we are delaying surgery. We are starting with endocrine therapy first, and we delay the surgery. So we try to adapt the guidelines during this period in a way that the patients do not come too much to the hospital. We try to avoid the presence of the patient in the hospital. Also, blood tests, if it can be done close to the patient's home, is going to be done. They just get us the results. We are going to do all those measures to try to avoid the spread of the disease.
Thank you, Evandro. Fabrice?
Yes, we have quite the same policies, I would say. In France, we try to establish, as Solange said, it is not exactly guidelines, but we try to be homogeneous within all the boards for all the tumor boards, and every board has written I would say guidance in order to address what kind of treatment may be postponed, what kind of treatment is absolutely needed. All the patients come to the daycare hospital and everything. Then what seems to be what is for us very important is to have this discussion and this decision done on a multidisciplinary way and very well explained to the patient, even if it is by phone, in order to preclude any contamination by the virus in coming to the hospital. But I think it's very important for the patient to receive as many information as needed. It's what we try to do, and we try especially to postpone treatment with immunotherapies, because we know that those treatments have a very long half-life. Then it's clearly possible to make this treatment every 4, 6, or maybe more weeks, rather than trying to do that during the COVID crisis.
Thank you, Fabrice. Marina?
So, hello. So we paid the price to be the first, I think. So I work in a comprehensive cancer centers, and so we decided to keep the comprehensive cancer center COVID-free, but we were not able to do this. And so we are in the 5th week of COVID. And immediately we started, for example, to deliver the oral drugs directly to the home of the patients. We organized a very strong phone team, calling every day the patients in order not to feel them abandoned, because after 5 weeks the people start to suffer that they can continue the treatments and so on. And as all the people said, we started to delay everything and to reduce as much as possible the visits. But I can tell you that this is a wonderful plan if the virus will stay with us just for 1 month or 2 months. But if the virus will start, as someone says, until the end of the year, I think that we have the problem that potentially we can increase the mortality for tumor. So I think that we have to measure what we are doing, because you can delay for 1 month, 2 months, but maybe at a certain point some decisions must be taken. The other point that was not mentioned now is the problem of the end of life. So in the beginning, we had the problems that the hospices were COVID-free. And so if you have a patient COVID positive at the end of life, it's very difficult to manage the situation because there are no COVID positive places for the end of life. And the same for the people going, the healthcare professionals going to the home of the patients. So I think that you have to be prepared also for this, to create also some protected places also for the end of life. And I think that my country that was not digitalized, so I think that the people were not using the internet so much. We started to do the TMB by web. We started to be connected with the patients. And there are also some experiments now in Italy. Maybe you know that in South Korea, it's important also tracing the contacts. So we are trying to also to put some apps on the patients and to follow where they are going, what are their contacts, to reduce as much as possible the contacts.
Thank you, Marina. Toni?
Yeah, all what I want to say that there are the local guideline we develop within our hospital, and these are depending for the cancer patient, whether they're back for follow-up, for which we know we can extend the follow-up in some. So those patients that come on LHRH agonists that have prostate cancer every 3 months, they can go 4 and 6 months if the PSA is stable. Those that are following with scans where the guidelines that have, let's say, bladder cancer, as I'm a GU oncologist, where the guidelines 6 to 12 months, if they're on 6 months, we can easily transition them within 9 to 12 months, on and on and on. And there is the folks that get systemic treatment. And for these, we are not really asking them to stay home yet, but we are making some judgment calls. So for those patients on immunotherapy that have been in complete response or in deep partial response, this is maybe the time to discuss holding the immunotherapy a bit. For patients that want to start some adjuvant therapies, let's say that don't have an overall survival benefit, we're having a more heart-to-heart discussion about coming here. We had recently a case of a patient where we started asking ourselves, someone with a muscle-invasive bladder cancer, where we know the options are going directly to cystectomy and getting adjuvant therapy, neoadjuvant therapy following by cystectomy, or doing chemoradiation therapy. So we started to weigh on, what is plus and minus of each. Now, regarding guidelines, just the last thing I want to mention that a lot of societies jumped, and thank goodness they jumped fast on guidelines. Very, very useful. NCCN have guidelines posted on their website, but specifically ASCO, the organization I'm part of now. Since I can't share my screen, I want to share my phone screen here. If you go to ASCO.org, the first thing that comes out is how to deal with COVID-19 and resources for patient care, provider and practice, even updates about the program, the ASCO 2020, which will be virtual, as well as government and reimbursement things specific to the US practices. So I think this is another very important resource, like also ESMO website.
Thank you, Toni. Catherine?
So I'd like to add something about the end-of-life care at our hospital, because we have very strict visitation policy right now. So pretty much no one can enter the hospital except he's a patient or a healthcare worker and he has a reason to come in. And right now there are some exceptions to those rules, and it's, for example, when a patient is dying, the relatives or one relative can come, but he needs to get like a script from a doctor who says it's absolutely necessary that he comes in, and there has to be written who's where's the patient, on what ward, and of course the visitor has to be symptom free, and then he can come in. And what we have been doing is that we have a very good cooperation with our palliative care team, and usually they come to the wards and talk to us directly, but when this all started, they offered us to do it over phone. So if we have like any questions or we need palliative care consultant, there's a very short distance now to just call them and get them to work together on how to manage a patient also with COVID, because they might not can go to the palliative care ward, but we can manage them on our wards and just have the very short route to our palliative care team.
Thank you. Nicola?
Yes, I just would like to say a few words about patients who are potentially, that could be potentially enrolled onto clinical trials. Many of us are working in institutions where we have many protocols, active protocols. So at this time, we have decided to stop the enrollment of new patients, and for other patients, maybe on oral therapies, we are trying to find a way with the sponsor of the trial to send them the treatment, and the assessment will be done and will be provided in local hospitals of the patient, so that we can reduce the access of these patients in our center.
Thank you, Nicola. And to end it up, Nicola?
Well, thank you very much. I think we have to watch very much after our co-workers, because end-of-life care obviously is already very stressful on the teams anyway. But I think under these special conditions, it's an intensive challenge. And I think it's very important to establish mechanisms to also give our co-workers time to reflect their experiences. Just to give you an example, in our emergency room now, we have had in the last couple of days several young family fathers that came in with a COVID pneumonia that had to be intubated. but for quarantine reasons, they could not see the family before intubation. So they were all saying goodbye via FaceTime. And I think this is all the skiers coming back from Austria. So this is why there are so many young males right now in Munich. And this is an extremely negative experience for the team. And I think for these kind of settings, we need to establish consultations for the team as early as possible.
Thank you so very much. And with that, we can close up question 5 and move on to question 6. Given the cancellations of all major meetings and congresses at the moment, how can we stay up to date with the latest developments in oncology despite COVID-19? What tools and channels should we be using to stay informed? And how and in what format will new trial data be presented? For this, we can start off with Solange.
Yes, thank you. It's a very sad year for that, right? You try to organize many educational meetings and we cancel one after the other one, very often last minute. So one thing which is important to state here is if you cancel something last minute, it's impossible to change its format because it's just something which is too stable in time. So we need to be a little bit more proactive in the way we perceive the future. I know it's not easy, but we have to imagine and try to imagine how the situation will be in August, in September, in November, in order to still provide education, because canceling is just against education. So we try to move in ESMO to anticipate, and maybe it's good for the global situation and the environment, how to potentially deal with some of our meetings, even big ones, in a purely virtual format. But not just last minute and making just a profit paper being presented, like, of course, ASCO will have to do. But you can do lots of things virtually. You can pre-record many things, wonderful educational sessions, for example. But you need to be aware that it's going to be virtual and prepare for that. It's a different way to work. It's a bit less glamour, not to travel to Chicago, Singapore, whatever. But it might be the way we need to learn, maybe not all the times, but very often, for the COVID story, but maybe beyond the COVID story. So somehow we will learn to move to virtual format. Waiting for that, we need to communicate. We need to write papers. We need to publish, even if not presented at meetings. So we need to potentially move to the old way. We publish data obtained from clinical trials without the spotlights. We just publish and make it available to the community.
Excellent. Thank you very much, Solange. Very well put. Virtual is seems to be a great way to go, and it's something that we really have to take advantage of. Toni?
Yeah, I mean, Solange is right. This is going to be, I would say, if I have to predict something, is the pre versus the post COVID-19 times. That's what our maybe children or ourselves gonna talk about at some point. And education and how to communicate information is gonna be very important. I think we all know the value of social media, although we have to be very careful because social media could be sometimes like drinking from a hose, and some of the things that are said may not be totally correct or totally vetted. Remember, this doesn't go into peer review, but continue what we do normally through virtual. ASCO, as you all know, will have a virtual scientific meeting where some of the presentation will be pre-recorded, and who knows, maybe they will have more than the usual attendees. Everybody can tune into these virtual meetings. This could be a win-win for everyone. The educational meeting, though, session may happen later, not at the same time. I can tell you immediately at our place at Dana-Farber Harvard Cancer Center, we started having a virtual noon at 12 noon every day, science talks that are live and recorded. The first one was, I believe, on Monday was with Nobel laureate, my mentor and colleague, Dr. Bill Kalin, who gave it. And every day, every other day, they will be one. I know next week, Dr. Carl June gonna give it. So to get engaged as much as possible. And this is maybe the new way to do things that, will prepare us, once we get over COVID-19.
Thank you, Toni. Marina?
I see I have two daughters, one is 20 and one is 22, and they are doing lessons every day for university through the the Microsoft Teams that Bill and Melinda Gates donated to the Italian universities. So I think that we have a lot of instruments to continue to educate the people through the web. So we have just to implement this part. The other point is that this is what you are doing is an example. I think that we are in the time of sharing. So we need to share everything very quickly because we need to adapt our daily practice with the story of COVID-19. So I think that every experiment to share experiences, guidelines, everything, I think it's very important now.
Thank you, Marina. Gilberto?
I have nothing to add. I think everything has been said. It was the right thing to do for us to postpone all the talks, and we have reverted everything that we can to virtual as well, including our tumor boards.
Excellent. Gilberto, I will move now to Michael.
Yes. Thank you very much. So I have just one aspect to add, that my take from the interaction with the Chinese colleagues is that they're using a lot of TCM, traditional Chinese medicine. So I would not expect too much information on randomized trials on Western, so-called Western drugs on COVID concerning their experience over the last 3 to 4 months. So actually we are starting right now to do these trials, tocilizumab and so forth. And it will take some time until we have results. So I think it will be very important that we have registers or registries which are open to the public, where we can have a daily analysis of data that are being gathered, even without a review process, so that everybody working on this topic can get his own impression. There's, for example, a registry by ESMID, which is called LEOS, which is open, and you can get a lot of information on relevant epidemiology and ACE inhibitor and so forth. And I think this kind of information prior to peer review will be critical for the next weeks.
Thank you. Gilberto?
Thank you, Gil. So that brings us to other registries efforts that are ongoing. So in the US, we have more than 30 universities and cancer centers teaming up together with the CCC19. This is COVID-19 and Cancer Consortium. We have already gone live, and we are at www.cccnteam.us.org. And what we're doing, this is an internet effort. We already have exemption from the Vanderbilt IRB so that physicians can enter data without personal identifiers. We're keeping to one investigator from institution so that we don't have duplication of the data. And we already have a number of patients that have been entered into the database, and we hope that in a week or two, we might start having data that we can share with everybody. So let me just repeat that website is ccc19us.org. And I'll be happy to talk about it in more detail with anybody who would like to.
Thank you very much, Gilberto. And of course, a little plug in here, OncoAlert maintains its commitment to its colleagues and will continue to report and inform to the best of our abilities. However, we would like to formally make it known to the oncology societies that we belong to, that they have the support of the network. So whatever we can do to actually advance these virtual meetings or whatever we can help with, we're here. So use us. I did promise our discussants that we would finish at 15, which is we're coming up here soon. So I know that some people have to log on or log off. We have one question left, but I wanted to give the people that needed to log off the opportunity to thank them and say goodbye. I believe, Toni, you have to leave?
I do, and I want to thank OncoAlert and what you started, Gil, which was a dream, a bit over a year ago, how it's taking over the field by storm. I want to thank all my colleagues here, sending them health waves all over, and please stay healthy, and thank you for all what you do.
Thank you so much, Toni. Really appreciate you being here. Stay safe. Everybody else, we just have one more question left, if it's okay. The question is, cancer patients are all in a difficult position already. With the coronavirus outbreak, they have now also to deal with additional burdens, like belonging to a risk group, fear of being infected, not being able to be visited by friends or family. What can we do in our position to comfort them? But also, what can we do for ourselves to cope with the mental stress in the clinics? How do you advise oncologists, especially young oncologists, to deal with the mental stress and burnout that many colleagues are seeing? Like, for example, I belong to a Berlin group, so maybe we could have a virtual Berlin group. These are small groups of 5 to 6 people, of clinicians that discuss not the clinical part of cases, but the emotional hardships that come with it. And that way you could actually address some of this stress that is coming and also the burnout. So in order to get this, I would really like Catherine to take the floor on this one. Catherine?
Thank you very much. I think in Germany, we're only at the beginning, like it was said before, and we are already starting to feel like the stress it's taking on our patients and on us. And I think what we can do for our patients is that we are even more available for questions, because we have from our cancer center, we have a telephone hotline where patients from outside can call in and they get an oncologist who answers questions on outpatients appointments, on how to proceed. And I think that's very important. And our psycho-oncologists have implemented an on-call team that's available not only by phone, but they can also come in at night, on the weekends, whenever it's necessary. So the psycho-oncology support is getting more implemented on our wards. And I think as for ourselves, the most important thing is that we keep talking, I think, to our colleagues on the other wards in the other countries, because they maybe have experienced the same things. And our psycho-oncologists just offered to talk to us as well. So they're not only taking care of the patients, but they also take care of us right now. And I think that's the most important thing, that we talk about what we're experiencing, because it's like we said, we're at the very beginning, and I think it's really, really scary, not only for the patients, but for us as well, because we don't really know what's going to happen over the next weeks and months. So I think that's the most important thing, talk to our patients and talk to each other and try to, I think the virtual Berlin group is a perfect idea to how to cope with all that.
Catherine, I just wanted to ask you, is this something that is Berlin groups, is it something that is already incorporated in Germany or?
So not? We don't officially have that, but I can just tell from my personal experience that I have a few friends who are working in the same hospital, and we're having fixed appointments where we call each other and talk about what's happening, because it's pretty much the only way we can do that, because I'm on the COVID ward right now. So I cannot go to the other wards and talk to them. And so we're keeping it virtual and talk over the phone and discuss what we're experiencing. And I think for me, that's really, really helpful.
That's excellent. Kevin?
Thanks, Gil. I think an important fear factor for a lot of our patients, next to all the issues that comes with isolation, is the fact that they get confronted on a daily basis several times with the fact that they have a higher risk when they would get the COVID-19. And for a lot of patients, it's really bothersome to get confronted with that several times. I think we can try to comfort them on that point by underlining that while the risk is higher, still the vast majority of onco patients still will recover if they get COVID-19. And I have learned the previous weeks that there's a lot of misunderstanding under our patients there. And I think we play an important role to put that into the right perspective. On the other hand, also, there's a lot of fear if they will receive the oncological treatment, they need. And also there, I think we need to stress that, as we had to do with before COVID-19, still during this pandemic, whenever we think that the benefit of the oncological treatment is outweighing the risk which is related to the treatment, that we will continue to treat the patient as he or she should be treated. And of course, for the hospitalized patients, it's very important, I think, that not only the medical, but also every paramedical division in the hospital is switching gears towards different professional organization, and even psychological teams. They really have divided up towards people who are now dedicated to give support on the COVID wards, while other ones are dedicated to give psychological support on the non-COVID ward. So I think all these items are important to comfort them. And one last thing I would like to add is something I've learned from a patient yesterday. Whenever things go well regarding the oncological situation, it's very helpful for the patients when we focus on the oncological situation, when we don't try to focus too much on all the other things going on. That can help patients, at least who are in oncological situation, with a clear response, for example, in a metastatic setting. This can be a major relief for a lot of patients from the psychological burden they encounter.
Thank you, Kevin. Megan?
Yes, I think if you take the picture of a ship preparing for a storm, the number one rule is first you prepare the ship and then you send the crew to rest. So as we are recruiting many people right now into a hospital, this is not in parallel exactly to the need of the resources. So when we have people or wards that are overstaffed, we try to send everybody home. And the administration is very uncomplicated about counting the hours. So I think this is also to give the people some room for private life and for breathing. You cannot only have them working, because the energy has to last not only for a week, but rather for several weeks.
Thank you very much. Evandro?
I think that has been said. We feel that if there is stress, even if I'm not personally experiencing COVID patients at this moment, we see there is a stress around the healthcare professionals, a stress with the patients. I think you need to try to give psychological support for the healthcare professionals, and in Belgium they have some activities on this, and I think that's very important. For the patients, you need to reassure them they are going to get the best treatment. Even if you have to adapt the treatment to avoid the visits, you are still treating their cancer, you are still treating the patients, and you are not abandoning them. So I think that's the most important, to keep the relationship that you have with your patient. So to keep that lively and to reassure them that, okay, we're going to go through this together.
Thank you. Solange?
Not so much to add, apart from the ironic situation in which we stay. We are in a time where, due to the crisis and the difficulty we all have to face, and I'm sure we all share a kind of anxiety. We're all frightened to see how long it will last, when will it end, how many of our friends, colleagues, patients will be affected. It's all the unknowns which make our daily life a little heavy to kind of face when you wake up in the morning. So more than ever, we would need to meet, communicate, chat, drink a glass of wine together, and we cannot. So ironically, we need to be able to communicate better with less means of communications, or at least a less direct communication. So I think it's quite interesting to see that I feel like we will be able, and Jill, you will agree with me, we will be able potentially to be closer without being together. And it's probably about sharing more things by writing, communicating more by electronic digital media, being more connected, because it's a different type of connection. It has to be more often, it has to be more kind of detailed in order to understand what we mean. So I think we will learn how to be more connected and even more together than before when we cannot meet. Same for patients. By calling more often the patients because you did not see them, they feel very reassured about the fact that you can potentially replace face-to-face by being a little more connected. We did call our COVID positive patients every day. because in the beginning we were frightened that our COVID positive cancer patients would not do well. And they felt so comforted by the fact that communication can even be better by the phone or by a web platform than we were used to do before. So I think this crisis revealed the worst and the best of societies and communication. And I must say, honestly, in that COVID crisis, I have seen only the best at the time being. So we might learn something out of it, even if it's extremely painful for all of us, right?
Absolutely agree. What do they say? That necessity is the mother of innovation. So I think we were all coming together using what we have for the betterment of our patients. Not only that, but also to come together as a medical community. And it's just, it's amazing, even the interaction that we have within OncoAlert daily. It's just great to have such a global medical community that really believes in what they're doing and believes that we can make a difference. So it's a wonderful thing. Fabrice?
Yes, just some simple points to add regarding what Solange said regarding the digital communication. We set up a specific web page on our website with the most frequent question the patient had, and then they can access to this page and have the answer. And we are also sending every 2 days some scientific information, very, I would say, simplified and summarized for all of the workers in our hospital. Then they are able to understand what happens, what are the epidemiological data, what we are talking about when we are talking about the treatment, what happens in the other country. Very simple summary, but send it to all of the workers of the hospital, and then they feel they are better placed to understand what happens. And the last point I would say regarding our colleagues is also to give them, I think we should not forget, because we don't know how many time it will last. It's very important to try to keep some rest for all of our colleagues and all the teams. And we try to protect them, having at least 1 week off every 3 weeks in order for them to have some rest. It's still possible at the moment. We know that in countries where the crisis is still on the top, like in Italy, it's impossible. But we try to protect them still at that time in order for them to be prepared and in good shape when the crisis will be the most important one.
And Gilberto.
Thank you, Guillaume. Thank you, everybody. So I have a very simple message that I want to finish with for the general public and for healthcare workers. Those of you who are not on essential activities and who are watching us, stay home. In all areas where we have community spread, do not go to work. Stay home as much as you can. Of course, you should still do your regular things, go to groceries if needed, or anything that is essential, but to try to minimize that as much as possible. And for healthcare workers, it is extremely important that you stay well. So the message about sleeping well and being in contact with friends and socially have contact so that you can remain healthy is extremely important. And finally, there's one thing that we are all afraid of, which is to bring the virus home with us. And there's a few simple things that many of us are doing that are useful. There are colleagues that have gone through extremes of not going home for weeks at a time, and that happened in both Italy and China. And what we are all doing, and some people who are working in ER and are definitely seeing COVID-19 patients, of course, you do maybe have to go through some of these extremes. But for all those of us that are not dealing with patients with COVID-19 as a daily function, we should take simple precautions. Keep the shoes out. Whatever you're wearing for that day, get those clothes and put it straight in your washer. If you can have a separate area in your apartment or house that you can use for these things, please do. Some families that have 2 physicians in families are not working at the same time because of this, or they have sent kids to different places. Some physicians I know who work in ERs are kind of quarantining an area of the house for them with themselves. And if you are distancing physically from family and friends, please do keep in touch by FaceTime, Twitter, whatever electronic means you can, because it's extremely important that we keep healthcare workers well throughout this crisis. This is not a week. This is not 2 weeks. This is going to be for months. So please stay healthy. We need all of you.
Indeed. So as we wrap up today's roundtable, I would like to just give the floor over to our discussants for any specific take-home messages that they would like to give everyone. We'll start with Megan.
Yes, I would just like to tell you a very quick story. In Germany, there's a competition for national cancer centers, and we applied for one of those 29 days ago. And the major theme of our application was patient-oriented cancer care. And now, as we have discussed before, the whole medical field has switched to community-oriented cancer care or care of patients. And this is really a dramatic development, which in many respects is certainly a negative development. However, as they say, in every end of something, there's also a new beginning. And there are so many positive things I'm seeing right now in our field. I see we don't only see less pollution on this planet, we see extremely highly motivated teams, nurses, doctors, and people coming from outside and helping us in the hospital, people who are delivering fresh fruits to our ward every day and so forth. And we see a really much improved communication systems and skills. And I'm very positive that after this is over, and we'll most certainly win this battle together, that's for sure, there will be also many positive lessons that we have learned in the field of medicine in general and in cancer care in particular.
Thank you very much. Kevin?
Yeah, maybe a little bit out of the box, but I think it stays important that we as healthcare workers dealing with this pandemic, we should try to dedicate at least some daily time also for non-COVID things, for non-COVID projects, try to continue on a lower level some projects that were ongoing, try a virtual journal club with topics that are non-COVID related, try to take some time to linger on the internet, not focusing only on the COVID news. I think this can help a lot, especially before going to sleep, to refuel the batteries actually for the next day.
Thank you, Kevin. Evandro?
I think that this is a very hard moment to everyone, not only healthcare professionals, but for individuals. I think that we're really going through a hard time, but we're gonna get there. And I think that you should do the maximum you can as an individual and as a healthcare professional. As a healthcare professional, we have to hang in there. We have to help our patients. We have to help each other. For the non-healthcare professional, for those who really do not need to go to work, I really recommend to stay home, follow the regulations on your country, strictly follow the things. This will last some weeks, some months, but then afterward, we can get together again. So please follow what is recommended in your country. Try to avoid the spread of this virus.
Thank you, Evandro. Solange?
Yes, maybe 2 words that we have in mind sometimes when we discuss this event and this COVID pandemic is what will be the post, and it's always good to think about after, what will remain after the crisis. And there are 2 political words we need to keep in mind. First of all, I think we have recreated in our societies some, I would say, connections and some ways to share difficulties that have to remain. The societies have gone more separated time after time. We were kind of selfish in the way we evolved, and suddenly we need to care for each other. So maybe that's one thing. It's more like a Christian perception. I'm not Christian, but something to keep. But more than that, the healthcare systems have been fragilized in the recent 20 years a lot. Oncology and in general, all the financing of healthcare system has been reduced to the minimum, and we all suffered the reduction in personnel, the reduction in budgets. So the whole system has been misconsidered or not enough considered recently. So I hope that after this viral crisis has gone, we will be able to potentially reframe the priorities of societies in order to make them probably more comprehensive, more more in the solidarity, but more than that, to value more how much state health, what hospital can do when they are for everyone, is important on a daily basis and in terms of crisis. So kind of growing around COVID to make hospital and healthcare being well considered in a society, a new birth for them.
Thank you, Solange. Felipe, any take-home messages?
I think we learned a lot from you guys. I just have to thank. We here in Brazil, we're just watching the epidemics arrive. We're just starting to peak. We don't have a organized health system as you have. We are super scared here on how we're going to cope with all this virus coming and all the problems that we have in your health system. So your words, Dr. Peters, were very reassuring for us. We have to really focus on turning into society and building health systems to help people and not focus only on the individual, but in the collectivity. I think we have a hard time here in Brazil. I'm super worried. I try to alarm people, especially the lay people. I do lots of videos for lay people. And I hope this message get to them because we need everyone helping so we could go through this time with the less casualties possible. So thank you very much for your time and your information. It was very precious for us.
Thank you, Felipe. And Nicola?
So just to conclude, I would like to say that obviously now it's a dramatic time for Italy, and this time is especially dramatic for Bergamo, my hometown, and I would like to invite all of you to read the nice article that is published a couple of days ago on the New England Journal of Medicine from my town, from the hospital of my hometown, exactly Bergamo. So, but as Marina said before, of course we are dealing with a moving target. We don't know how long this crisis will last. Maybe some months, but there are some forecasts saying also till the end of the year. We really don't know. By the way, I think we have to keep a positive message, and I think that this horrible crisis will teach everyone something quite positive. We have to retain these positive lessons that have been already said during this debate. So thank you for your time and thank you for your attention. Thank you.
Thank you, Nicola. Fabrice?
Yes, just to say that cancer patients don't have to pay twice to the COVID and to the cancer. And we have to inform and to educate the population to stay home, to protect themselves. We have to protect our patients from the COVID. And we have also to protect themselves to be healthy in order to deliver to these cancer patients the care they are needed. And I think it's what we should try to do.
Excellent. And I guess I will wrap it up. My take-home message is that we have to do our share about fighting misinformation every chance we get. I know I wrapped it up last time with the same message, but it's a really big message. I can't log into Facebook or Twitter without actually having misinformation everywhere. And it's affecting my friends, it's affecting my family. And it's a really good thing that I love it when they come to me. It's like, is this true? So the amount of information that they're bombarded with is incredible. And the problem is that this is affecting our patients. It's putting our patients at risk. So we have to fight online as much as we fight in the clinics because we have to protect them. So my advice is the time for the timid physician online is over, and it's time to engage and take on the fight. So we thank you all, and we thank you all of our discussants for participating. On behalf of all of us at OncoAlert, we thank all of our friends and colleagues for watching. We wish them courage. We're all in this fight together, and together we will definitely overcome the situation. So thank you all. Good night from Europe to the rest of the world.